Hello, everybody. Welcome back to Blood Matters, a podcast for nurses. I am Emma Chalmers, one of your co-hosts, and I'm joined once again by Michelle. Hi, Michelle. How are you?
Hi, Emma. Lovely. Thank you. Having a great day so far.
Nice and sunny down in London. It's not sunny in Scotland. Well, the bit that I'm in. So thanks everyone for joining us for this episode of the podcast. We're really looking forward to today. It's going to be a little bit different. We're actually going to talk about CAR T cells, which are not stem cell transplants, but have some parallels, I guess you could probably say. What do you think, Michelle?
Well, I think we'll wait to hear from our guests and
that's true.
They've got to say about it.
That's true. So I think what I'll do here then is just tell everybody who one of our guests is. So I'm really happy to say that we're going to be joined by Marjola, who is one of the paediatric nurses who works at Bambino Gesù Children's Hospital in Rome. And I apologize if I have mucked up the name for that, if any of our Italian listeners are cringing at my pronunciation. Marjola also works as a nurse in our paediatric nurses group through the EBMT, and she has a special interest in CAR T cells in children. And then who else have we got joining us, Michelle?
Yeah, so again, to join us today, discussing the differences and similarities of CAR T cells and stem cell transplants, really thinking about what nurses might need to know. We've also got Ruth Clout, who's the lead nurse for haematology and TY education and the inpatient unit working at the Christie Hospital in Manchester, so up north in the UK. She qualified in 1999 from King's College in London and then had a job in haematology at Guy's Hospital. She's actually worked in haematology oncology for the past 23 years. So she's now a new kid on the block, and she's certainly got a lot of experience, and we're very lucky to have her on the pod today. She's currently the working party nurse in the immune biology cell therapy working party. So it's really great to benefit from her expertise on the pod.
Amazing. I think some folk would argue that Manchester's not too north. That's me saying it from Scotland in the UK, which is much further north and much colder than Manchester. So this is one that I'm really looking forward to us doing today, because I have a personal special interest in CAR T cells. I think it's one of the most amazing creations that's come out of research in the last decade. I think I don't have the words apparently today to talk about how I'm looking forward to this podcast. So without further ado, I think we'll say hello to our guests and we will start in with questions. So for our first guest, as Michelle's already said, we've got Ruth. Good morning, Ruth. Could you give us a little introduction to yourself and tell us just a little bit about what you do?
Hi, thanks, Emma. So my name's Ruth Clout. I'm the lead nurse for the haematology transplant and TYA education programme, and also the main inpatient unit at the Christie Hospital in Manchester.
So hi, Ruth. So I'm going to go straight into the questions here. So first of all, can you explain or tell us all a bit about the main differences between CAR T cell therapy and stem cell therapy? You know, I guess this is fairly basic level, but sometimes it's a question that people are a little too afraid to ask.
Yeah, okay, thank you, Michelle. So within stem cell transplant, there's two main types of transplant that we're using really. So you've got your autologous or you've got your allogeneic. So your autologous is using the patient's own stem cells. These are collected from the patient. They would be frozen and be reinfused at a later date following high dose chemotherapy. And these are used for sort of diseases such as myeloma and lymphoma. An allogeneic is different, obviously, because it's using a donor's immune system and donor stem cells to replace the bone marrow of the patient with a healthy donor. And CAR T therapy is a different approach, and it uses, so it's chimeric antigen T cell receptor, and it's a type of immunotherapy. It's collecting T cells from the patients, and these T cells are then re-engineered to give them the armor really that they need to be able to recognize the cancer cell and kill the cancer cell off. So there are some distinct differences really between CAR T therapy and transplantation, but there's also some similarities as well.
Thanks very much, Emma. Ruth, I'm going to hand over to Emma now.
That was actually, I love that, just very basic, simple, differentiation between the two. What might be the symptoms that patients could experience after like a CAR T cell infusion, and why are they a little bit different to if they've had a stem cell return?
Yeah, so as I say, there are some similarities and uniqueness between both. And within sort of transplant, you're going to see things like your nausea and vomiting, your neutropenia, your risk of infection, which you're likely to see within CAR T therapy as well. However, there are distinct side effects such as cytokine release syndrome and immune effector cell associated neurological syndrome, which are very common and documented toxicities that can occur with and quite unique to CAR T therapy. Within CAR T therapy, you're unlikely to see things like the severity of mucositis that you see in transplant, acute GVHD. So I'm talking about sort of the autologous CAR T products. You won't see GVHD within those. So as I say, you can see that there are the differences between the two.
And all of the side effects seem to have these really long, tongue-twisting names, don't they? We love an abbreviation. Love a bit of CRS and ICANS instead of the long terms. Michelle, you've got another question, haven't you?
Yeah, actually, before I move on, could you just describe, go into detail a bit with what CRS means and what ICANS means?
Yeah, absolutely. So CRS is it's an inflammatory response that's triggered because of the release of the CAR T cytokines from the CAR T cells. And so as they go into the patient's body, the CAR T cells recognize the cancer cells, and it causes this inflammatory response and releases cytokines into the body, which causes cytokine release syndrome. And this, one of the early sort of signs of this is a raised temperature. The patients may get a low blood pressure and also have an oxygen requirement. And there is a grading system that we use for this. So it's graded as 0 to 4. We use the American Society of Transplantation and Cellular Therapy grading consensus grading, which is a really simple and easy to use tool to grade these patients on their cytokine release syndrome. And ICANS, again, there's a similar grading system for this, and this is probably a little bit the mechanisms of it are probably a little bit less and well understood than what it is within cytokine release syndrome. But essentially, the patient is at risk of developing neurological toxicities. So we would ask the patient 10 questions a day, and 9 questions, and get them to write a sentence. And we use that as a really sort of nice grading tool to see if there's any changes on their neurological status. Depending on what they score, if they score sort of if they get 9 questions correct and 1 wrong, this would constitute a grade 1, and then obviously the grading criteria then just sort of moves up as the score decreases.
And these can be quite discrete little changes in terms of the neurosymptoms, can't they? They'd be quite easy to overlook, I guess, is probably something to consider. Yeah, and it's very often it's subtle changes. So for example, like the writing test is a really, really good tool. So asking the patient to write a standard sentence, the same one each day, so you've got something to compare to. And also things like word finding. So patients might just really try and sort of, struggle trying to get those words out and not really able to say what they need to say. We do find that relatives who are coming in each day are able to report those symptoms, and they may notice something. So now that obviously COVID restrictions have really, relaxed and things, it does mean that actually we are able to have the benefit of having family members and friends to be able to say they're just a little bit different today, there's something not quite right. Whereas if you're the nurse on shift, you might not have been looking after that patient the day before, so you are relying on the accuracy of that tool to assess them. And the way I'm finding difficulties are not the same as what I have on a Friday afternoon. No, or what I have this morning. But yeah, between us all. Sorry, Michelle, carry on.
Thanks a lot, Ruth. That's really, really good, and a really sweet explanation of where we're at with CRS and ICANS. I'm just going to ask you a bit about the IEC forum. I understand there's an IEC forum. I excuse the helicopter that's flying above my my house right now. So this has been set up through the EBMT nurses group. It's on the EBMT website. Can you tell us a little bit about it, please, Ruth?
Yeah, so the Immune Effector Cell Forum was set up. It was before I came to the Cell Therapy Working Party. Rose Ellard had sort of put a lot of planning in place to do this, and it went live last year. So the forum is a place where we would encourage nurses and AHPs looking after or having experience with patients having CAR T therapy and other types of cellular therapy to actually use this as a platform to have discussions, to post their thoughts, their experiences. There are resources on there. There's links to things like the nurse's textbook, the CAR T handbook and things. And it's really something that, you know, I'd love to see more people joining this and having more conversations. Currently it is probably a little bit quiet, so I'd urge everyone just to share that amongst their teams and get some conversations going. You know, I don't want it to be that it's just me posting things on there all the time. I'd like people just to say, oh, we found this in our centre, and what do you do about this? So it's quite nice to share those things in a European you know, collaborative and sharing basis, rather than just emailing someone down the road because you know them, and it's about really just sharing those things in a European perspective.
And we will link it in the description for the podcast, Ruth, as well, so
that
people can easily go and click on the button and find the forum and start asking their questions. My last question, I think, for you at the moment, Ruth, until we bring you back to the quick fire round, is going to be, what do nurses need to consider most when caring for patients who are receiving CAR T cells?
So there's several things, isn't there, with this? I think that these patients have got relapsed and refractory disease. They're a vulnerable group of patients. They've got challenges, diseases to treat. So meeting their patient expectations is really important. Setting out very clear information to them, providing them with all the information is really essential. There is the sort of, you know, thinking about things like the advanced care planning and that aspect to it, because these patients, whilst we hope that they will get into a good remission, they also may not, and they may relapse, you know, and sadly die of their disease. The other thing I think that nurses obviously need to consider is thinking about how they, the assessment of their toxicities and how they support those patients, using the grading systems, monitoring them, and keeping on top of those any deteriorations in their toxicities that can occur during their cell therapy, CAR T therapy.
Great, thank you. We will come back to you, so hang on with us. But Michelle is going to move into the first question for Marjola.
Brilliant. Thanks a lot, Ruth. That was really great, and look forward to chatting to you in a bit. So Marjola, just tell us briefly a bit about yourself and what you do.
Yes, thank you, Michelle. Good morning. My name is Marjola Gjergji, and I am a pediatric registered nurse in stem cell transplant and cellular therapy and gene therapy at Bambino Gesù Children's Hospital in Rome.
Thank you very much, Marjola. It's a real pleasure to welcome you to the pod today. Are there any apparent differences, do you think, when giving CAR T to pediatric patients when you compare that experience to adult patients, do you think?
Yes, well, the pediatric population, as in everything, I would say, are a little bit some steps back comparing to the adults' reality. So for now, the only approved CAR T product for the treatment of pediatric population is the CD19 Letiza cell, which includes the pediatric and young adults in patients with up to 25 years old of age with the BLL, and the adult with the LBCL refractory and relapse, or in post-relapse, or in secondary relapse of the disease. So basically, the relapse or the multiple relapse or refractory of the conventional therapies is, in this case of the BLL, is the main inclusion criteria of having the CAR T in children.
Thanks very much, Marjola. I think it's really interesting, isn't it, that you know, there's a fairly narrow view still within paediatrics, whereas, you know, you look at the adult world and, you know, we have a lot of excitement around CAR for myeloma and, you know, a significant population of patients that could potentially benefit from this treatment. You know, I think it's interesting how the developments are actually quite different within those two populations. Really interesting, and certainly lots of food for thought there. Thank you.
I'm not a pediatric nurse, which is why I have some questions that I love to learn. I love to hear this. This might be a bit of a contentious question, actually, but do you think is there a move towards giving CAR T cells to young patients with B-cell ALL versus giving them an allo transplant, do you think?
It depends, because we can do CAR T to patients with multiple relapse who never get the allo transplant before, and then bringing them to perform an allo transplant as a consolidation, or also patients who had allo transplant and then relapse, then you can move to CAR T. So till now there is no CAR T in frontline treatment, but I cannot exclude that this will be in the next future. Yeah,
that makes sense. So it's almost like we've got another weapon for treating BLL in pediatric patients.
Yeah,
instead of an alternative.
Yeah, and it's more caution in pediatric reality, I would say, than treating in patients with these therapies. In general, with every kind of therapies, pediatric populations are more, you have a big eye, bigger than in adults, I would say. I never worked with adults, but as I know and as my experience was, yeah.
It feels very much at the moment as though they're working to complement each other rather than replace one another, certainly with where we're at right now. I'm going to just move on to my my next question, Marjola. So Ruth has spoken about CRS and ICANS in the adult setting, but could tell us a little bit about how these are assessed in pediatrics, particularly really young children?
Yeah, I would say that there is not that much difference between the treating, between the adult patients and pediatric patients treating CRS and ICANS. So the CRS grading scale is almost the same with the pediatric management suggestions. For example, the only thing which can include the dose of the tocilizumab, for example, less than 30 kilograms, the dose is difference between 12 milligram per kilo, or also the dexamethasone. So the CRS continues being the most common side effect, the most frequent side effect in pediatric population as well. And in some studies show that in this case, more than 77% of pediatric population and in young adults developed CRS after the treatment with the CD19. So is also, and all of these patients in these studies showed that they required an intensive care support. So it's critical as in adults, I would say. And regarding the ICANS, there is a pediatric grading scale called CAPD, which is the Conroe assessment of pediatric delirium. And if we want to just mention some numbers, 25 to 44% in publishing trials with the CD19 or also CD22 CAR T cells was performed in children with hematological malignancies. Based on my personal experience, I can say that ICANS are more difficult to recognize in children, also, of course, based on their age, but because they can camouflage very well the symptoms, and sometimes you have to be very expert, I would say, in this field to act immediately. and to recognize them.
Yeah, it feels like you have a whole different, with the various ages of patients, you have some who are probably able to report symptoms or describe symptoms a little bit more readily in sort of your older kids, but in the younger kids and infants, it must be incredibly hard to identify the range of symptoms to be able to offer that scoring. And so it's great that there are specific paediatric assessment scales for being able to do that, to be able to support that in practice.
Yeah, and I would add also the education of the family, because they are always the children, and a well-educated parent in this field is very much helpful for us to get to know the child better and the symptoms or whatever it's related to.
Yeah, I can see that. Thank you so much, Marjola. I'm going to hand back to Emma.
Okay, so guys, we're now moving on to our quick fire round. So these are questions where it's just a 1 or 2 sentence answer, no pressure, hopefully. Michelle and I, again, will alternate the questions, but we'll ask a question and then you can both answer, and then we'll go on to the next question. So my first quick fire question is, what concerns are there in terms of late effects for both the pediatric patients and the adult patients? So Ruth, we'll go to you first and think about late effects in adults.
Yeah, so two of the main ones really are things like B-cell aplasia, hypergammaglobulinemia. That's always one hard to get your tongue around, and infective complications where patients can have prolonged cytopenias. So they're the sort of main ones that we're seeing further down the line, sort of after 30 days onwards.
Grand. And Marjola, what about late effects for pediatric patients?
Well, there are no much data about that in the pediatric population as regarding on the product, the only approved product that we have till now. But the only thing that I would say is that also the late effects are conducted by a multidisciplinary team. So, and nurses in this case have their own and their important role. Also, the prolonged cytopenias, as Ruth said, and hypogammaglobulinemia and infections are very common to be considered as a very late effect. And in this case, also the GVHD is in some recent publications confirmed it in 4 pediatric patients to post-Kymriah. They had the GVHD as not like as a very much late effect, but it's something that we are facing in patients with after CAR Ts. And EHA and EBMT also have a very nice recommendation on how to manage the prolonged late effects.
Great.
Also in populations too.
Awesome, thank you very much. We'll link that in as well. Michelle's got the next question.
Brilliant, thank you very much, Emma. So I'm going to go to you first, Ruth, with this one. So what's your favourite thing about CAR T cells?
I mean, they're just really clever how they work. I think the fact that they've been able to genetically modify the patient's T cells to be able to then use that to target its cancer, it's incredible.
Brilliant, thank you. And Marjola?
I would say definitely the mechanism of actions of CAR Ts. This is probably the first thing that when I heard for the first time about CAR Ts, and despite the funny name of the CAR, I would say the mechanism of actions fascinates me a lot, yeah.
Brilliant. I'm going to slightly spin that question now. I'm going to go to you first, Marjola. What's your least favourite thing about CAR T?
My least favourite?
If you have one, maybe you love everything about CAR T.
Yeah, well, I told you, I mean, how they really work and how you can see the comparing patients, the MRI before and after CAR T is very fascinating. So yes, I would definitely say how it works, so the mechanism.
So Ruth, I'll offer that question to you as well. What's your least favourite thing about CAR T?
Well, I think Mario and I have both said that we like sort of how they work, the mechanism, and I suppose the flip side to that is when they don't work, you know, they can't obviously work for everybody. And there was, you know, a lot of hope on this when this first kind of came out and everything, and there still is. But obviously, sadly, there are patients that do fail. So that's probably my least favourite thing about it.
Thank you, Ruth. I'm going to hand over now to Emma to ask the next quickfire question.
I am on it. I also tend to agree with you guys about the mechanism of action being my favorite thing about CAR T cells, just in case anybody had, you know, a desire to know my opinions. So the next quickfire round question is, what advice would you give to nurses who are nervous about working at a centre that's about to start a CAR T service? We'll go to Ruth first. What do you think?
So taking us back to sort of, wow, nearly five years ago, coming up to it, when we first sort of got the approval for this, there was a real nervousness around it. We didn't know sort of what to expect. We could only see what was in the published data from the studies. And, you know, I kind of thought that we were going to have every patient down to ICU. And actually, in reality, nurses that work in cellular therapy and transplantation have really experienced in looking after sick patients. They manage sick transplant patients day in, day out, and actually they can do this. They've got this. You know, they're very, very good at recognising acutely unwell patients. And I think that that is something that nervousness, once we had a few patients under our belt, you know, really has gone away, and it's become very much our standard practice. It's part of our daily care, which is lovely to see. It's really nice to see how that's progressed from what all our initial anxiety.
Great, yeah, that's reassuring for services that are maybe just starting up. Marjola, what about yourself? What would you tell nurses?
Well, I would say that a very good action in working environment starts with a very good education. So especially in our dynamic and innovative field, education is the key, I would say. So knowledge is awareness and responsibility, and makes us freer and more autonomous at work. So definitely I would always recommend to never stop keeping updating and to try to invest more and more in education.
As an educator, that makes my heart happy. Thank you for that answer. Michelle has our last quick fire round question before we start wrapping up the pod.
Yeah, I love what both of you have said about how this has become essentially embedded within everyday practice. And, you know, we welcome CAR T like we welcome all of the other patients with their treatments that come onto our units, and without the sense of anxiety that you might have had when you were initially starting out. And I really like that. And I think that says a lot about, you know, how dynamic our services are, and how agile we are as nurses in terms of the ability to embrace new concepts and really new protocols of care, which I think is amazing. So my final quick fire question is, what is your hope for CAR T in the future? And I'm going to go to Marjola first.
My hope for the future, which I think does not seem so far, is to have CAR T for everything. Mm-hmm. But most of all, that it can include also more and more solid tumors in this case, and brain tumors, and more hope. As I'm pediatric, more hope for the pediatric patients with more approved protocols, because we, as I showed you, we have only one, unfortunately. But I think that something new and something more, hopefully, we will have in the next future.
Yeah, it's coming, isn't it? It's coming.
Yeah.
And Ruth, what about yourself? What's your hope?
Probably a similar answer. Actually, it's more, you know, disease indications that open it up to sort of patients with, you know, other, you know, complex hematological and solid tumours as well. You know, there's obviously a lot going on in the background around those with TCRs and TILs, etc. So I think, yeah, trying to treat these challenging diseases in a wider population would be brilliant.
Thank you very much. Yeah, I think all of us would hope for more equity of access to treatments like this. I think in our countries, yes, there are restrictions and, there are some challenges in getting treatment, but we know at least those treatments are available for those people that fall within that indication. And we certainly know and understand that in countries elsewhere, the situation, the position can be really, really different. And I guess, being able to deliver treatments with that address the toxicities that a lot of our patients experience currently would be, a real that would be on my wish list, I think, for the future, that that patients can have these in a much less complicated way with less treatment side effects, and so that then means a much smoother recovery from the treatments.
I'd love to see us giving CAR earlier in the sort of the process, in the timeline of treatments. I think it would be really good to see it, not be the thing that we have to give as a last effort, really, for certain patients, like maybe a bit earlier on, maybe before stem cell transplant if they've had one of those. Who knows what the future will bring? Maybe we'll come back in a year or so, Michelle, do another podcast about CAR, and it'll be an entirely different conversation. Fingers crossed.
There are certainly a lot of trials at the moment where that is being looked at, where CAR is being offered a lot earlier in the pathway, and certainly prior to stem cell transplantation. So the future's bright. I think there is a lot yet to learn and to know.
And isn't it fun being right in the midst of it all and doing that learning and doing that doing and contributing to that body of evidence?
Yeah.
That brings us to the end of the questions for our guests. So I'm going to take this opportunity to say thank you very much, Ruth and Marjola, for joining us today. It's been a great conversation. I think we could have talked about a lot more, but we don't want to have a podcast that lasts for multiple days. But if there are topics that people want, we can certainly do that. So thank you for joining us and giving us some of your time today. We really appreciate it.
Oh, thank you for having us.
Thank you very much.
Thank you, Michelle.
No, thank you again, Ruth and Marjola, and Emma, as always. A huge amount of fun co-hosting the pod with you. Thanks.
Love it. So what an interesting podcast, Michelle. How have you enjoyed it today?
Yeah, absolutely fascinating, and a great couple of guests as well, with Ruth Clout and Marjola Gjergji. Really, really great and amazing to have the benefit of hearing the adult and the pediatric experience. Yes. And the similarities and differences around the treatment and treatment delivery, treatment availability, assessment, side effects. Just great, actually. Really, really good. So yeah, I feel really good about this one.
I love this one, as everybody knows, that CAR T is my little passion project, and we've skimmed the surface of CAR T. Really, we haven't done a full deep dive, but for those that are interested in learning a little bit more, I've got a couple of places to signpost you. So within the EBMT nurses textbook, there is a chapter on CAR T cells. As Ruth said, we've got the IEC forum, so the Immune Effector Cell forum. Please go and post some questions. No question is wrong to ask. Nothing's too simple. Nobody's going to be judgy. We all just want to share the knowledge and make sure that everybody is feeling comfortable around CAR T cells. Now, this is probably a good time as well to plug that every year EBMT and EHA have a CAR T meeting. It's usually around February in the year. And in 2024, it's going to be in Valencia in Spain, which will be lovely. Never been, but I'm looking forward to it. And as always, it's been fabulous to have you guys listening to our podcast. And we really appreciate every time you come on and you have a little listen to us, our little corner of the world talking about transplants and everything related. Please note, though, you can look at our previous podcasts on whatever platform you're on. They will all be there for you to have a wee listen to, and we do encourage you to do that, because we talk about some really interesting things, don't we, Michelle? We've got great topics.
We do indeed, yeah, and we've got some great topics coming up as well, which we will share with you in due course.
We're really excited. We've pretty much got the program for the rest of the year sort of planned out, and I think that people are really going to enjoy what we're going to talk about. But if you want to know something, if you want us to do a topic in particular, then please let us know, because we want this podcast to be led as much by the listeners as it is by Michelle and I and the team in the background. So please send your suggestions into the usual places: EBMT website, Twitter, anywhere else that you can think. Please leave comments on the recordings if you're listening on a platform that allows you to do so, because we want to make this as you-led as possible, is a good way to say it, I think. So I would just like to say a final thank you to Michelle for being my co-host once again. It's always fun doing these recordings.
Thank you, Emma. Thank you to the EBMT team, and thank you to our amazing guests. And thanks again to you all for listening.
And you enjoy yourselves and stay safe.